Hello and good evening. It's 8 p.m. UK time, therefore it is time to start our live event once again. It's good to be back once again with you. And well, as always, I am your host, Caroline. And as always, please let me know that you can hear me loud and clear. And with us today, we have another special guest. It's Dr. Antonio Rodrigues. Hi, Dr. Antonio. How are you feeling
great.
today?
Thank you. Really a pleasure to be here again and to share this topic with your guests.
Excellent. Thank you so much for joining us once again. Of course, this is our second edition when it comes to Stronger Together initiative. So I am very, very excited that you've decided to, again, join us and present definitely interesting topic, which is hyperinsulinemia, hyperprolactinemia, and immune thyroid disease causing recurrent IVF failure. So thank you for that topic. This is definitely interesting, and I'm sure all of our patients will find it very, very useful and interesting. And before we start with the presentation, as always, please let me remind you that Stronger Together has been brought to you in order for you to find out a bit on various topics when it comes to IVF. We are focusing this time on insights from top fertility experts, of course, from different countries, and we are focusing on successful IVF treatment after failed attempts. This is another topic in this kind of field. So well, and also, as always, please let me remind you that all the events have been brought to you thanks to our ambassadors and partners. You can see them right here. As always, without their help, it would be very difficult to arrange such Stronger Together initiative. So thank you to all of them for their support. And as always, please let me remind you once more that we will start with the presentation, and after that it will be time for your questions. So you just need to put your questions in the chat section. You can do it now during presentation or later on, and Dr. Rodrigues will be more than happy to help you out, I am sure, with any of your questions. And I just need to mention as well that Dr. Rodrigues is a reproductive medicine specialist and the founder and director of Medfem Fertility Clinic, which is located in the Republic of South Africa. So we are connected today with South Africa. It's really nice to have you back with us. And well, it is time to start with the presentation. Okay, Dr. Rodrigues?
Fantastic. Thank you very much.
Excellent. Thank you.
So I thought I'd look at very basic stuff in terms of recurrent failures, and I'm not going into a lot of the other heavy stuff that one reads about. And the reason I decided to do that is insulin, prolactin, and thyroid disease are really critical to creating an environment in both egg and sperm and in the uterus to lead to a situation where one has better pregnancy rates. And I think if we focus on these simple things sometimes, which we forget about or we don't overmanage and treat properly, we can get recurrent IVF failures. The first slide that I'm going to show you is really saying what you need as a patient to have a successful IVF, and a successful IVF is defined as a live birth. The first two important things is you need what we call chromosomally normal or euploid eggs and sperm. So in simple terms, unfortunately in the female, approximately anything from 60+% of eggs are actually abnormal, and in the rest of the group we call it normal or euploid eggs. And in males, and this is very important, males play a very important factor in the whole story. It's not just about a guy with a sperm and you put a sperm into an egg and it's always going to be fine. The sperm can be chromosomally abnormal. So in order to achieve a healthy, chromosomally normal, and you will hear this term euploid if you have any dealings with pre-genetic screening, which means normal in Latin, you need a normal egg, a normal sperm to fertilize, and then you land up with a chromosomally normal euploid embryo. The majority of failed IVFs are related to abnormal embryos. So if you've got a normal embryo, you're starting at a positive point. Then the next step is you need an anatomically, so in simple terms, means that the uterus must be normal. It must have a normal lining. And we can see in that slide, there's what we call a triple line. There's a thickening in the uterus. There's no growths in this particular uterus. There's no fibroids pushing on it. There's no polyps or septums in the uterus that can prevent an embryo from implanting. So we need the lining to be good so that the embryo can be received properly by that uterus. And we need nothing that is going to inhibit the area that that embryo implants in. So fibroids that push on that uterus, a septum or a wall in the uterus, polyps in the uterus, all of those things can lead to failure due to what we call an anatomical problem. And then the last thing we need is an immunologically normal uterus. So in order for an embryo to grow in uterus, we must remember, because half the embryo is coming from the male, it is what we call a antigen. So that in simple terms means that the body would recognize normally, if you put a sperm into someone's bloodstream, it would recognize it as abnormal and create a reaction. But in the uterus has been designed very cleverly that, in fact, the fact that there's an antigen there, this half the chromosomes and the antigens coming from the husband, the uterus actually behaves in a way that it sets up what we call blocking antibodies. So these antibodies sit in the uterus and prevent rejection of the actual fetus, of the embryo, the fetus. And when this immune system is not functioning properly, these blocking antibodies aren't made, and there's a lot of immune factors called tumor necrosis factors, which actually lead to the embryo being rejected. And what I'm going to discuss tonight does cover this area as well. So that's what we need to achieve a normal pregnancy. In terms of what happens if there is high insulin levels, hyperprolactin levels, or immune thyroid disease, and in fact, just underactive thyroid without an immune factor, these factors are disturbed. So what happens? In all of them, both the insulin, prolactin, and thyroid, there's an increased number of chromosomally abnormal, poor quality eggs. So, and an increased number of chromosomally abnormal, poor quality sperm. So my message here is that we need to test males as well. So a lot of times males aren't tested for insulin, prolactin, or thyroid disease, but they play a critical role. A sperm is not just about putting a sperm into an egg and it will make a healthy embryo. Not at all. That male needs to be healthy. He needs to have normal hormonal levels, and we'll go through each one in the next few slides. So I emphasize this because about 10, 15 years ago, we would have blamed everything on the egg. We would have said, these embryos are not good, the egg's playing a big role. And it came to our knowledge, and we started doing research on insulin in men around 15 years ago, and found, in fact, in males, they had high insulin levels, and as soon as you corrected the insulin levels, the quality of the embryo was improved and your pregnancy rates went up. And obviously, if something's wrong with the uterus, as I discussed earlier, or if you've got these factors that can reject the embryo, such as immune thyroid disease, which we will discuss further in the next few slides. Now, as we know from what we're dealing with at the moment with COVID, we know that certain things like overweight, diabetes, hypertension, they lead to an increased predisposition to disease. In simple terms, what this means is we recognized over the last 20 years, actually, in females, that insulin plays a critical role in what happens in the body. Normal insulin levels, what should really happen is when you wake up in the morning, insulin should be at a low level, You have your breakfast, the insulin goes up in order to deal with the sugar load that came from your breakfast, brings the sugars back to normal, and the insulin goes down again. But what we found is in a lot of patients, and they don't all have to have a weight problem. We have some patients that are in fact even underweight. They can have a high insulin level, and it needs to be a fasting insulin. And we take a level of anything above 9 as abnormal. And what that means is that if that level is higher than 9, patients have a predisposition to creating problems with their sugars. On the right side, we can see there what insulin does, it helps glucose move into cells. When the insulin goes up, you move more sugar and glucose into cells. And what happens generally is there can be weight gain because it increased fatty acids and it gets deposited into fat tissue. But more importantly, what actually happens in the ovary. And what happens in the ovary during the development of that egg, you need a constant flow of sugar, not an up and down flow of sugar. And anyone who has high insulin levels will often find that they get tired, that post-eating, they drop their blood sugars, they've got to eat again, they get cravings, they can be moody and irritable, they have mid-afternoon dips in their sugars, they have post-eating dips after having dinner. And all of those are a sign that you've got a hypersensitivity to insulin, and the ovary doesn't like it. It cannot develop a strong, healthy egg. And importantly, you can have a chromosomally normal egg developing, and if your insulin is high, it can actually change that chromosomally normal egg into an abnormal egg during the final division of the egg, which happens once you trigger ovulation. This little egg divides so that it puts out half the chromosomes, and during that division, it can make an abnormal eggs. So this particular problem leads to an increased incidence of abnormal eggs, and it leads to an increased incidence of chromosomally abnormal embryos, and it leads to an incidence of higher miscarriage rates because of that. The good thing is that it's easy to diagnose. It's a blood test, and once you've got the diagnosis, you can manage it. Why is it happening? Well, it's quite clear. We do have very high carbohydrate diets generally worldwide. All the things that are on that picture, we all know about them. It's usually all the nice things in life. But from my point of view, if you're trying to have a child, there's nothing wrong with having certain parts of these things in your diet, but it has to be in moderation. What it does, so we said it raises insulin, it causes weight gain in some people, tiredness, and high cholesterol. If we then look at what is the further thing, and we've all heard of metabolic syndrome, which means that there's a tendency to have high insulin levels, and with that comes an overweightness, which is usually in the abdominal area. So anyone who's got a height abdominal circumference ratio, so in other words, if you do a tape measure of your abdomen and it is more than 50% of your compared to your height, then you could have metabolic syndrome. But I also want to emphasize there are a lot of thin women who have high insulins, and that once you get to the metabolic syndrome phase, you often find that people will have gout, prediabetes, they will have hypertension, coronary artery disease. Now, in terms of the female, insulin plays a big role in polycystic ovarian syndrome. Now, I'm not going to go into a lot of detail about polycystic ovaries, but I'm going to say that a patient might have what we call insulin sensitivity, which means that they have sugar lows related to normal insulin levels, and then you'll get someone who has high insulin levels. And if you have very high egg numbers and you have high insulin levels or insulin sensitivity, what it does is the dominant follicle, the one egg that's going to become the dominant egg, finds it very difficult to suppress all the other eggs that have been recruited during the early phase of the cycle. And because of this fluctuation of sugars, the energy in that particular egg cell cannot actually get the follicle to grow usually beyond 14 millimeters. If it does grow sometimes, it grows very slowly, so the egg becomes abnormal with time, or in fact, in a certain group, they don't ovulate at all. So you can have abnormal eggs with this, you can have abnormal embryos, and the other thing that happens if the insulin levels are high is that the uterine lining is often thin, and that uterine lining is critical for implantation of a healthy embryo. If we then look at the male, and I must emphasize the male, males are often left out of these testings. So a male can have absolutely a normal semen analysis, can fertilize an egg perfectly, or they can in fact have very low sperm counts and abnormal sperm. It's a spectrum. But it's important that there are males who have absolutely normal semen analyses, and yet that particular sperm, if they have high insulin, will actually create an embryo that is not healthy. And we've done a lot of research on this in our particular clinic over the last 10 years. And again, the male can create an abnormal poor embryo, and obviously he can have an abnormal semen analysis if his insulin levels are high. So what's the best eating plan? Well, if everything's normal, then you should have a balanced eating plan. You just maintain your weight, you're doing fine, and if your insulins are normal. If you have polycystic ovaries with high insulin levels, and you have a high carbohydrate diet, then one should go on to a low glycemic diet, which in simple terms, you just look at carbohydrates that have low glycemic index, a balanced eating plan, watching your refined carbohydrates, and that will generally do the trick. And then the other thing that one can resort to, especially if you're really struggling with poor eggs or poor sperm or cannot lose weight, and this works particularly well in men that are overweight, is what we call the Banting diet, or the high protein diet with no carbohydrates. That has a benefit in certain people and works very well, and especially in males. And the dieting is not about weight loss. I know weight loss comes, but if you're eating properly, the environment both for the egg and the sperm will be improved, and you will have a better quality embryo. And again, why does IVF fail mostly? Because something's wrong with the embryo. If the insulin's high, there's a higher chance that you will have a lot of embryos that are abnormal. If you manage your diet, if you manage the insulin levels, then the chances of that you will have better eggs, better quality, and normal chromosomal embryos is higher. And lastly, the uterus will be more receptive because the endometrial lining's fine. The receptors for estrogen and progesterone work better when the cells in the uterus have the right amount of carbohydrates going in to give energy to those particular cells in the uterus. And then what are the medical treatments? So diet is critical. Metformin is the best, is the treatment that is generally prescribed for polycystic ovaries. We use the long-acting glucophage because the quick-acting metformins that you have to take many times a day have a lot of side effects. So we use a long-acting glucophage tablet, which is taken once a day, and those doses are increased until one achieves normal insulin levels. And the other natural product that's on the market and has had a lot of research done on it is called inositol, and that has a definite positive benefit in IVF patients, improved egg quality, and therefore improved embryos. And obviously with those improved embryos, they are chromosomally normal, and therefore higher pregnancy rates and higher live birth rates. What about prolactin? Now, prolactin, the only time prolactin should be high, and prolactin is made in the pituitary gland, which is the same place that FSH and LH come from, which is follicle stimulating hormone and luteinizing hormone and thyroid stimulating hormone. So those four hormones are critical from the hypothalamus. The only time that it is raised is in pregnancy. So as soon as a woman is pregnant, her prolactin goes up naturally, and obviously during breastfeeding it goes up very high. And as you know, if we look at women who are breastfeeding, they have a lower fertility rate, so they almost have a natural contraceptive during breastfeeding. And the reason for this is that the raised prolactin levels reduce the ability of FSH and LH to be made from the pituitary. They also cause problems in terms of a thinning in the lining of the uterus. So they cause the following things in the female: poor eggs and embryos because of the change in FSH and LH. They cause lack of ovulation. So often, again, women who breastfeed will not ovulate until they stop breastfeeding. And importantly, they cause a thin uterine lining. So it's almost a natural contraceptive. Now, and in the male, this is again important, it causes abnormal semen analysis in the male. So often they will have a lower motility in the male, and they will have lower counts, and a very easy treatment, which we'll come to in a second. What causes this prolactin to go up in situations which are not related to pregnancy or breastfeeding? So both in the male and female, stress plays a big role. And if prolactin's high, there is a correlation between high prolactin and the patients having underlying endometriosis. So those two do go together. Certain medications and the antidepressants play a big role in that. So a lot of the psychiatric drugs can actually cause raised prolactin levels. And if there's scarring on the breast area, the scarring can also promote high prolactin levels. And what will happen is the symptoms that you present with are often headaches and breast tenderness in the female, and both in the male and female there can be lactation or breast milk secretion, and obviously the other things on the fertility side can lead to lack of periods and no ovulation. The treatment is very simple. We use what we call a dopamine agonist. It's something that acts like dopamine, and by that it actually starts to inhibit the prolactin and get the environment back to normal. And the ones that are used are the two that are mentioned there. The trade name for the carbocholine is Dostinex, and bromocriptine is Parladel, and they work very well. There is one other cause of very high prolactins, and that is a prolactin tumor in the pituitary gland. This is not a common cause, but it is there. The treatment is usually medical, and usually in those patients they have a 4 to 5 times high level of prolactin. But from a fertility point of view, in order to promote the health and wellness of an embryo, we need to treat any prolactin levels, even if they're marginally raised. So it's very important to treat prolactin, again, to get that chromosomally normal embryo and a good environment in the uterus. What about thyroid disease? Now, thyroid disease is very common. Approximately 30% of women and a certain percentage of men will have an underactive thyroid, and we're seeing more and more males getting this. And it's probably related to the sort of speed of life and the amount of work we have to do. And thyroid plays a critical role in cellular health and cellular metabolism and how the cell works. But importantly, in infertility, the level of TSH, if it has to be below 2.5, if it's above 2.5, it's abnormal. So this is a fertility-related diagnosis, and that's very important because we see a lot of women who come in and will have a thin lining in the uterus. They will not ovulate properly. They will have either infertility or recurrent miscarriages, and those levels that are just above 2.5 haven't been treated. And all you're doing is giving this very cheap thyroid hormone, which actually fixes the problem. What are the type of symptoms that you can have with hypothyroidism? First of all, sometimes weight gain. one of the very important ones is coldness of the hands and feet. So a lower body temperature, coldness of the hands and feet, constipation, dry skin, sometimes weight gain, fogginess of the head, no ovulation. So there's a lot of symptoms, and one needs to treat this and make sure that the thyroid functions properly. What does it do? It causes poor egg quality, poor embryos, and that means abnormal embryos in terms of chromosomes, lack of ovulation, and then importantly, a thin or a very thick uterine lining that is not receptive to an embryo. And again, back to the male, it causes abnormal semen analysis. It can cause problems with motility count. It can cause problems with the ability of the sperm to bind to the egg and to fertilize an egg naturally. The treatment is simple. It's a tablet a day and needs to be controlled accurately. Within the context of thyroid disease, we do come up with what we call autoimmune thyroid disease. What happens in the human body is sometimes we develop antibodies against a particular tissue. And autoimmune thyroid disease is a common problem. And in simple terms, the patient's immune system actually attacks and can damage the thyroid. If you have antibodies, it doesn't always mean that your thyroid will be over or underactive at that moment in time. But the studies have shown that this thyroid antibodies are associated with two factors in the uterus. The one is that what we call uterine receptor problems. So this is the ability of the uterus to respond properly to estrogen, progesterone, and implantation of an embryo. And the other one is that if there are antibodies, it's a marker for other immune causes of recurrent implantation, miscarriages, and reduced live birth rates. And what happens in this group, there's a raised level of what we call tumor necrosis factor. So what that is a factor that treats the embryo as a tumor. Now we know that these blocking antibodies and the immune system in the uterus is at such a level that the embryo is not rejected. And when you've got these other factors available, then it can be rejected. We use a treatment protocol in our practice, which includes 80 to 100 milligrams of Disprin. That's for helping the blood supply to the uterus. We use cortisone in small doses to inhibit the antibody, and we use immunoglobulins both pre-transfer and during the first 10 weeks of pregnancy. So in summary, I've tried to give you very simple factors that play such a critical role both in the male and female in the context of good eggs, good sperm, and therefore a normal embryo that's chromosomally normal. And at the end of the day, treating all these factors makes the uterus receptive not only to the lining and to the way it looks when one does a scan, but also to the immune system to prevent rejection of the embryo. Thank you.
Details you just provided, okay, definitely lots of that, and well, I am sure that you found this very, very useful. And now it is time for your questions. So there are some questions ready, so we can start with the questions, I guess. Dr. Rodrigues, are you ready for the questions?
Absolutely.
Perfect, thank you so much. Let's go. Our very first question. How much does hypothyroid and Hashimoto affect IVF, which is done with a donated embryo? Thank you for the very first question.
Yes, so again, if we look at what I've gone through now, the IV from the donated embryo, we're now getting an embryo that is potentially very normal. But if we don't treat the thyroid in such a way that you've got the levels of thyroid hormone right, and if we don't treat the immune side of it, we will have reduced implantation rates. So your hypothyroidism needs to have thyroid hormone replacement, and it needs to have levels of hormones that are controlled perfectly. And then as far as the antibody goes, as I say, we use that protocol protocol that I described, which contains dispirin, cortisone, and immunoglobulins. And from our experience, that deals with this problem perfectly.
Excellent. Thank you so much for the question, and of course your answer to that as well. And there are plenty more of the questions coming up. So let me go to the next one. Hi, I have had many PGS tested chromosome normal blastocyst transfer that have all failed. They can't find anything wrong with me. What tests should I be asking for?
Yeah, so I think that's an important question. I'm making assumptions that prove that the uterus, in terms of things like fibroids pushing in the uterus, a septum in the uterus, that those things have been ruled out. It's also important that that the fallopian tubes have been checked, that there's no blocked fallopian tubes. Because if there's a blocked fallopian tube at the end of the tube and it causes what we call a hydrosalpinx or water on the tube, that will prevent a normal embryo from implanting. There's a lot of other immunological factors that need to be looked at, such as anticardiolipins and antinuclear factors. Thyroid is important. I don't know if they've done your thyroid antibody, but if they haven't, that's important. I'm presuming, again, the fact that she's been through such a lot, that the lining looks good. And what we found in our particular experience with tested normal embryos, that it's critical, if you can, to put them back in the natural cycle. So you get a much better pregnancy rate if you use the natural cycle in terms of timing the natural cycle, releasing the egg, and timing the transfer for 5 days afterwards. There's also some new tests available these days where you can go and biopsy the uterus and see if the uterus is synchronized with the time that you're putting the embryos back. So I don't know how much she's had done, but those maybe some of those little tips will help.
And once again, thank you so much for that. And also there is a thank you from the previous question. Previous patient, of course. And let's go to the next question that we have right here. I recently had a failed IVF egg donor, the embryo quality being 2BB. Would it be my underactive thyroid that caused me not to become pregnant with this embryo?
So the answer to that could be yes. So if your thyroid is well controlled, hopefully they have checked your antibody levels. And if there are antibodies, again, we found that the protocol we use is really very effective. Obviously, if it's not a tested embryo, even though it was a donor egg, you've still got, maybe with the donor and you're putting one egg back, you might be kind of a 60% pregnancy rate, and it might go up to 75 if you're having 2 embryos back, but it's not 100. Even with it, and if the embryo is not tested, again, as I said in the beginning, most of the time the failure will be related to the embryo. But I must say that it's because you have a thyroid problem, please make sure you've had your antibodies checked, and one needs to manage that antibody environment to prevent rejection of the embryo.
And once again, thank you so much for that as well. And let's have a look. Of course, there are more questions coming up. I have hypothyroidism, taking thyroxine. During an egg retrieval, 3 oocytes responded to stimulation, but it was a cyst. Could this be due to underactive thyroid? What can I do for successful IVF next time?
Yes, so again, so long as that thyroid is controlled, then it wouldn't have been directly related to the thyroid, but it needs to be properly controlled. So the levels need to be normal. And then the other things that needs to be checked there is what we discussed. Insulin, fasting insulin levels can play a big role. And then prolactin can definitely play a big role. So thyroid and prolactin are linked. So your prolactin levels need to be normal. And what I often do, if someone's got a thyroid problem, I tend to let them come in a natural cycle and have a look at the physiology in that natural cycle, and see if their lining is perfect when they're not having an IVF program. And if it's not right, try and find a way of improving the natural look of that uterus, the natural physiology. If you can get the natural physiology to go well, then one should be able to retrieve better eggs the next time. And sometimes it's also just changing the stimulation in order to achieve a better result.
Excellent. Thank you so much once more for your question and, of course, for your assistance with that. And, of course, there's a thank you from the previous patient as well. And let's have a look. There is another question. What is the effect of hypothyroidism on fertility?
Yes, so again, you'll find that in terms of hypothyroidism, it often has a similar effect. So hypothyroid, overactive thyroid, those patients are going to be jittery, they're going to have lost weight, they are irritable. From a thyroid point of view, it can affect the lining of the uterus, and it is best to actually make sure that the overactive thyroid is controlled. Once it's in the normal range, it doesn't have an effect after that. But just remember that often those patients also have an antibody. So if you're going to be doing, if you're going to either fall pregnant naturally or you would have had an IVF, it's important to treat the antibody in terms of that protocol that I mentioned.
All right. Thank you so much for this once more. Okay, another interesting question. Can ADHD and anxiety medication impact prolactin levels?
Yeah, absolutely. Absolutely. So any of those central nervous system drugs can affect prolactin levels. So it should be checked and controlled. You cannot generally have too low a prolactin, but it can fluctuate. Usually it shows up on a program because the lining's not good during the program. Obviously, patients can have headaches and they have other symptoms, but it should be checked in anyone that's going to have an IVF program should have the insulin, prolactin, and thyroid checked.
Of course, understood perfectly. Thank you so much for that once again. And next question is, are there specific tests for thyroid patients when it comes to IVF and implantation?
Yes, so you know the levels of thyroid, you want your TSH, T3 and T4 and antithyroid antibodies. So those things in terms of control, you want your TSH below 2.5 and you want your T4 levels, which is the level of hormone that is active in the body, to be in the mid-range. And if that is all normal, mid to high range, because as soon as a pregnancy takes place, the demand for thyroid hormone goes up, and you don't need more tests than that. Definitely not more than that. So really simple tests and straightforward.
All right. Thank you so much for that. And at least for now, it looks like this is our last question that we will have. However, of course, if you have any left, then go ahead and type the questions in the chat section and go ahead and do it now. And the question is a bit longer. I have been told I have cysts and fibroids, but I'm not told this is preventing a successful egg transfer. I have had 4 failures. What should I ask to be tested on? I'm hypothyroid and type 2 diabetic. Second, I'm controlling my diabetes through Duet, but my last test result reading was 51. Should I go on metformin now before my next transfer?
Yes, again, I mean, she's been diagnosed as a diabetic, and generally type 2 diabetics always have raised insulin levels. So if one's trying to manage one just by diet, in terms of fertility, it's better to be on metformin and to actually try and bring that insulin level below 9. It plays an important role in, and I gather from her cyst, she's probably got polycystic type ovaries. You will get a better quality egg if you control insulin levels. And as far as the thyroid goes, back to the story, we need to control it properly because it can also cause problems with quality of eggs and number of eggs and a number of blastocysts that are formed. From our point of view, if fibroids are close to the lining of the uterus. So if they are more than closer than about 3, 4, 5 millimeters and are pushing on the cavity of the uterus, they will definitely affect implantation. We do see a lot of places and people worldwide who don't pay attention to that. From our point of view, if a fibroid is close to that uterus, it's going to actually cause a problem with implantation. And it's these days, if one focuses on getting rid of those fibroids, you definitely will have a better success rate, especially if you've been having failures. And 4 failures is a lot. I think she needs to also just make sure that there are no antibodies, whether that's thyroid or anti-nuclear factors or anticardiolipins. There's a lot of those immune factors that they should be paying attention to as well and managing during the from the transfer up to the 6 to 8 to 10 weeks of pregnancy.
And once again, thank you so much for your question, Nita, as well as your help with that. And in the meantime, there are 2 more questions. So let's go to the first one. You mentioned fasting insulin earlier. Is that HbA1c?
Right, so HbA1c is a measure of glucose in the hemoglobin in our bodies. That is for a diagnosis of diabetes. Insulin is a separate factor. It's measured separately. It's not routinely measured. We measure it routinely. And this is the thing. Most people that come for treatment are not diabetic. We see diabetics, but they're not diabetic. They are actually their insulin's raised. They are called insulin resistant. They are called pre-diabetics sometimes. And at the end of the day, it's a different measure. So it's a specific thing that needs to be asked for. And it's actually quite dramatic how many people have raised insulins and how rewarding it is to treat insulins. And in some people, that's the only reason they're not falling pregnant, because that insulin is playing a role in the female in creating an abnormal egg and creating an abnormal environment. You put them on it, the insulin goes to normal, and you get a pregnancy. And it plays a big role in the male. So they are different tests.
All right. Again, thank you so much for answering this question as well. And we have another question. Does acupuncture help with fibroids or a healthy embryo? Anything you can add on that?
Yeah, so if we look at fibroids, they will definitely not be affected by acupuncture. They definitely can't get smaller. It is a benign tumor. It is there. It's got a blood supply. It won't disappear with acupuncture. As far as healthy embryos go, acupuncture definitely has some value in some people, where it actually has a anti-stress mechanism. It definitely has been shown in some studies to be helpful in terms of implantation of the embryo. Having said that, I personally do not believe it will change it will make an abnormal egg into a normal egg. But I think acupuncture, for people that actually like going for it and enjoy it and are not stressed by it, it has definite benefits for that group of people.
All right, perfectly understood. Of course, thank you so much for this question, of course, as well. Next question is right here. I have raised insulin, but I can't take metformin at the moment due to fibromyalgia. What medication can I take?
Yeah, so that is a problem with some patients. So that natural product that I mentioned, inositol, and there are different types of inositol that are available. They have been shown medically and in other words, in research projects during IVF, to be of benefit. But, so you can take that, but what is critical then is also to be then on a strict eating plan in relation to carbohydrates. There's also Another drug that we are using in very specific people called Galvus. It's a relatively new anti-diabetic drug, and it might be tolerated more in fibromyalgia, and that could be used if you're really struggling to manage the insulin levels. But otherwise, inositol, which is a natural product, but very strict dietary habits, will get that right.
And thank you so much once more for that answer, of course. And there is a thank you already from one of the patients, actually, the patient that has asked this question. Thanks so much. Great presentation. Thank you so much. All right. So at least for now, it looks like this is our final question. But of course, if you have any left, this will be the final question to ask. Go ahead and type this in. If not, of course, we will be slowly finishing. But yes, there's another thank you, Dr. Rodrigues. As you can see, thank you very much. This was so useful.
Absolute pleasure.
Excellent. Thank you so much. And of course, we will be slowly finishing. But before we finish, I just want to let you know that, oh, sorry, one more question has popped out here. So what is the lowest acceptable TSH level?
Yeah, so it is a good question, because you'll find people over worry about TSH levels. So what we need is a TSH level below 2.5 and anything below it. And then the T4 level, which is the measure of the hormone that's actually doing the work, needs to be normal. So there's no such thing as a too low TSH level. So long as the T4 is now not becoming overactive. So you don't want to overtreat someone. So the T4 needs to be in the normal range, and then one can ignore the TSH levels so long as it's below 2.5.
All right. Again, thank you so much for your question and your help with that. And in the meantime, there is one more thank you, and actually comment, expert presentation. Thank you so much for that comment. Someone is typing, so I of course want to make sure that we have answered all the questions, so let's give it a minute. But in the meantime, let me just let you know that of course if you have any other questions, of course you can also go to this website. I have just sent it to you, and there is an option to contact Dr. Rodrigues and his team, and I am sure they will be more than happy to help you out a bit more. And one more question has shown right here. How much is my endometriosis affecting my blastocyst transfer?
So endometriosis has always been a contentious thing from our point of view forever. It's played a major role. It can play a major role in egg quality. So if we look at someone who we know has endometriosis and they go through an IVF process, 80% of the time the IVF will not be affected by it. But 15 to 20% of the time, the endometriosis, if it hasn't been treated, and usually that treatment would be surgical treatment rather than medical, in other words, it would be a laparoscopy and cleaned up, in that 15 to 20%, it can affect egg quality, it can affect embryo quality, therefore, and it can affect implantation. So if you're having recurrent failed blastocyst transfers, in our opinion, it's important to manage endometriosis and not ignore it.
All right, perfect. Thank you so much for answering this question on endometriosis as well. And next question is right here. Any natural elements one can take to raise healthy embryos?
Yes, so I think that the things that have been shown to be good, if vitamin D deficient, you should be on vitamin D. Coenzyme Q10 plays a role in women with very low egg reserve. DHEA can play a role in helping eggs. We do put all our patients on a combination of inositol, which is the thing that helps insulin, coenzyme Q10, certain vitamins, and certain amino acids. So we use these products almost routinely in our female patients, and in our male patients in South Africa, we use a product called Stamagro, which has high protein amino acids in it, and those amino acids have been designed in such a way to boost growth hormone, and that's given to our males at night to boost sperm, together with all the other essential antioxidants, and those are all important things. So balanced eating plan and taking extra minerals and vitamins and amino acids do play a role. They've all been shown to be worthwhile.
And another great question. Thank you so much, of course, and thank you for the answer. And actually, in the meantime, we have more questions coming up, right? So let's go ahead with them. Does hypertension managed with labetalol, impact a successful pregnancy in any way?
Yeah, so labetalol is a beta blocker, so that won't prevent pregnancy. It definitely won't. So no problem with that.
All right. Thank you so much for that. Okay, and next question is right here. Age 48, would you suspect endometriosis if not symptoms of it and doesn't show on a scan but had 6 failed implantations, donor transfers, had a natural pregnancy that ended in miscarriage at age 45?
Yes, so the interesting thing about endometriosis is it doesn't directly affect implantation, so it has more of effects on egg quality and how the kind of quality of egg you get, and obviously natural pregnancies. If there's endometriosis, it has a dramatic effect on the mucus, and if mucus is affected at the time of ovulation, it acts as a barrier to entry for the sperm. So in terms of this particular patient, the endometriosis wouldn't have played a direct role. Having said that, endometriosis is an autoimmune disease. You're having cells growing in the abdomen. So there is definitely an association between endometriosis and other conditions, including thyroid, including the other antibodies such as anticardiolipin, anti-nuclear factor. And obviously, as I mentioned earlier, prolactin levels can also be raised. So it's a question of just making sure that that uterine environment is perfectly fine. The problem with the 48-year-old, usually they are not ovulating or not properly, so you cannot use a natural transfer. And, so these extra little things need to be taken care of to make sure that that environment's right. And as I mentioned earlier, just to mention again, are your fallopian tubes open? Are any of them blocked, which can actually then lead to fluid killing off the egg? Are there any fibroids or septums in the uterus? So those things all need to be answered. But endometriosis on its own will not affect this outcome.
And once again, thank you so much for that. And let me have a look. Okay, there's another additional information from the very same patient. I have fibroids.
So I think it's, we do see patients where the fibroids are ignored. And if you have fibroids that are extending into that uterine cavity, either into it or pushing on it, they need to be removed. Unfortunately, they're playing a role. There's no question about it. I know doctors are very reluctant to actually do surgery because they worry about adhesions and causing scarring. If the surgery happens properly and is done in what we call fertility preserving surgery, and you make sure that you deal with the fibroids around that uterine lining, then they play a role. As she's put there, they apparently are intramural. Again, if they're intramural and not pushing onto that lining, they play no role, and they need to be around about 4 to 5 millimeters clear of the cavity of the uterus. So when the scan has been done, there needs to be you 4 to 5 millimeters away. If it's closer than that, it will interfere in the blood supply to the lining of the uterus and can prevent implantation. And if you're having all these failed IVFs and you've got fibroids, our personal recommendation, obviously I haven't seen your scan, would be to remove those fibroids.
Okay, excellent. Thank you so much for that advice, of course. And there's a thank you from the very same patient for your help here as well. Okay, and let me have a look. Again, someone is typing, so let me have a look. And yes, there is one more question. I was told that hybrids assist with the pregnancy when I was 28, but he removed it and I lost the baby.
Yeah, that's a bit contradictory. But at the end of the day, if the fibroid was removed and the uterus was normal and the operation was done fine, then the loss of the baby would not be directly linked to the fibroid unless there was more fibroids. Having said that, there is a condition that looks like fibroids called adenomyosis, and I'm not saying this patient has that, but adenomyosis is like having endometriosis in the uterus, and it causes a very thickened muscle in the uterus. Those particular patients definitely have a higher incidence of losing babies between 12 and 28 weeks. And because it's actually affected the muscle, you can't cut that tissue away. So again, hard to judge this particular situation, but if the uterus was normal after the operation, then generally the baby she would not have lost the baby related to the fibroid itself or the removal of the fibroid, let's put it that way.
And thank you for that explanation as well. Okay, and of course, let me have a look. Okay, we will be slowly finishing. I believe that this was our final question, but I would already like to thank everyone for joining us tonight, for all of your questions. I am definitely sure it has been helpful. And well, Dr. Rodrigues, there are some comments right here, so you just need to see that. Thank you very much. Great presentation. And of course, thank you and blessing to all wanted a healthy baby. Exactly. Thank you for that. We are definitely on board on that with that. And there's one more thank you for you right here. So thank you everyone for that. Dr. Rodrigues, it has been a pleasure to have you back with us. Thank you for your time. And of course, as always, you've been thorough with all the answers and of course, a great presentation. Is there anything you would like to add?
Yeah, what I'd like to add is I hope all of you that are on this call have your babies and just keep your spirits up. It's a hard journey, but having done this for 30 years, it's a very rewarding journey, and we've helped more than 20,000 people have babies over the years, and it can work and just persist and do all these little things and get checked properly and be checked again, and sometimes you have to get checked again and have blood tests again, and usually there's an answer, and there's always hope. There's always hope.
Excellent. Thank you so much for that fantastic finish. For sure, couldn't agree with this more. And well, all the best to all of you. But I also hope to see you tomorrow right here. We will have another session, this time with a fertility coach, Sarah Banks. So just join us at 8 p.m. UK time tomorrow. And she will be talking about IVF, failed IVF, what to ask when your IVF failed. So I believe this will be very, very useful for you as well. So I can only encourage you to join us tomorrow. And once again, this has been recorded, so it will be uploaded on our website tomorrow, myivfenses.com. So just go ahead and check this site. There will be all the upcoming events are right there. And of course, if you follow us on our Facebook or Instagram, all the events are also there, so you will be up to date with them. Thank you so much once more for joining. Everyone have a lovely and relaxing evening. As I've mentioned, I hope to see you tomorrow. And Dr. Rodrigues, once more, thank you so much. And well, I can only say till our next webinar, right?
Yeah, absolutely. Been a pleasure, always.
As always, exactly. Thank you so much. Again,
Take
have a lovely evening. Thank you. Bye.
care.